Good morning.
Good morning.
It's great to see a vibrant crowd here, excited to hear about new innovations in Alzheimer's and related dementias. When could we have said that in the past? New innovations in dementia. People were looking at dementia with a totally different lens than we do in this decade for sure, and even in the preceding decade as it was evolving. And I'm so happy that we're going to hear a talk that extends that concept. This is actually the first brain health symposium. So,
In Vermont.
Well, but we lead the country, I mean, really. So when we talk about dementia and brain health, there's a lot we've talked about traditionally in Vermont, but we've never had a symposium. So I'm looking at Rhonda thinking that in the back of her mind is like, this is the inaugural symposium. And there's going to be a tradition that we establish. This, of course, is a collaborative effort between the Alzheimer's Association of Vermont, my department, the Department of Health, and the other department that is housed in this building amongst many, which is the Department of Disabilities, Aging, and Independent Living. And there's also a connection with the UVM Center on Aging. Today we're going to hear from a leading dementia researcher, learn about our collaboration with UCLA on Vermont Alzheimer's and Dementia Project, and participate in one of two afternoon sessions on dementia care with empathy and a tailored training for occupational and physical therapists. VDH is doing a tremendous amount of work in this area now, and really the mission of our work through the Alzheimer's and Healthy Aging program is to reduce dementia risk amongst caregivers, improve early detection rates, increase care capacity in our rural areas, and reduce preventable hospitalizations among Vermonters who are living with dementia. In partnership with many of you here, we strive to make our state a place where we can all age well in the communities that we love. Together with Dale, the Department of Disabilities, Aging, and Independent Living, and many partners, we're aligning and implementing our state plans, including our new multi-sector plan on aging, which I'm sure everyone in this room is aware is called Age Strong Vermont. Now notice I did not use the word treatment in any of my discussion, not to certainly lower the importance of treatment for those currently living or seeing themselves passing into the area of dementia. However, there's so much excitement going on. I have absolutely zero doubt that our speaker will ignore treatment. But I really wanted to provide the public health view here, because so important is early detection, accurate detection, having the clinical community be poised to view this as potentially a preventable condition, and thinking about risk factors, protective factors, and how we can modify the risk factors in a favorable way. We also spend a lot of time in public health really looking at things on a population basis, and our population has not really heard these magical terms, brain health, to the degree that they need to, nor has, frankly, the clinical population heard the words brain health as much. It's kind of, I won't call it cutting edge, but it's certainly a novel and newer concept than we've had in the past. You know, the heart has always been a big focus, even the kidney, the connection with cardiorenal syndrome and what impact your health of your heart plays on your potential for developing chronic kidney disease. I think outpaced what we're going to be talking about here today, which is brain health, arguably the most important part of our entire body. So I'm really honored now to hand this over to my colleague, Howard Goodrow, who's the Executive Director of the Alzheimer's Association of Vermont, and he will then, I presume, introduce our speaker. Thank you.
I promise you don't have to be 6'4" or taller to stand up here and speak today. So, thank you, Dr. Levine. As Dr. Levine said, my name is Howard Goodrow. I'm the Executive Director of the Vermont chapter of the Alzheimer's Association. In New England alone, we have over 300,000 people living with this disease, dementia and Alzheimer's. Caring for those 300,000 people, we have well over 500,000 unpaid caregivers. That's an astounding number of people who are impacted by this disease, and those are only those over 65 years old, and those who identify and who have been identified as having the disease. So that number is woefully underrepresented. It's a sad disease, one that we're working very hard in the association to reach as many Vermonters as we possibly can. We have a small staff, but we're doing what we can at the State House. We're doing what we can with support groups and education programs, and we're raising funds for the research side of things. Having lost my mother with dementia last summer, I want to personally thank you all for the work you do in this field and the commitment you have to ending this disease. The Alzheimer's Association is a global force, connecting scientists in an effort to change the trajectory of the disease. We're fueling diverse research at every stage by identifying bold ideas, raising funds, and investing in groundbreaking, high-impact projects. Through innovative grant programs like Part the Cloud, we're propelling studies like US Pointer, which is part of Worldwide Fingers, an international network that's dedicated to investigating how lifestyle changes may reduce the risk of dementia. You've probably heard that up to 40% now is identified as lifestyle changes can actually impact whether or not you get this disease or not. Both of those studies I just mentioned, our keynote speaker is a part of. We're also investing in studies to learn how to best support caregivers and improve quality of life for people living with the disease. The association is currently funding nearly $430 million across the world in 56 countries. We don't target areas, we target science. So we're looking for the best. We're looking for the brightest. We're looking for innovative ideas. We're not looking to say, this person had a good idea once, we're going to fund them just because. We want to find the best stuff out there and we want to fund it. We encourage any of you who are in the field to apply for grants through us. If you have questions about what we do as an association, we might, and how we might work together, please pull me aside, or talk to Meg Polite, our advocacy director, or Joe Cotto, who's right over there, who's our program manager, senior program manager, or Liz McCarthy, who's in the back, who's our health system manager for New England. Her job keeps changing. She keeps adding states and subtracting states, but she's with us and doing a great job with us. So my job really today is to introduce our keynote speaker, and it's my pleasure to do so. I'm proud to say he's an Alzheimer's Association grant recipient. Dr. Stephen Salloway is an internationally recognized leader in clinical trials for the prevention and treatment of Alzheimer's disease. He's the founding director of the Memory and Aging Program at Butler Hospital in Rhode Island, the associate director of the Brown Center for Alzheimer's Disease Research, and a professor of neurology and psychiatry at the Department of Psychiatry and Human Behavior at the Warren Alpert Medical School of Brown University. I find myself feeling very underqualified when I talk about Dr. Salloway. He's an expert on amyloid-related imaging abnormalities and a member of the Alzheimer's Disease and Related Disorders Therapeutic Work Group, developing appropriate use recommendations to safely guide the clinical use of new disease-modifying treatments. He serves as a consultant for drug development to the NIH, the Alzheimer's Association, and the Alzheimer's Disease Drug Discovery Foundation. He's published over 400 scientific articles and abstracts and edited 3 books and lectures widely about early diagnosis and prevention of Alzheimer's disease. In fact, he's probably visited more countries in the last week and a half than I've ever been to. So he's probably a little jet lagged, but I know that won't slow him down. With that, I want to hope you will join me in welcoming Dr. Stephen Soloway.
Well, thanks, Howard. Thanks, Dr. Levine. And thanks to the organizers for inviting me and my wife, Diane, who we are co-conspirators in this effort, up to join you. And I want to salute you for hosting or organizing your first, or your inaugural and first brain health symposium. So hopefully there'll be many more to follow. Howard is absolutely right about that last part of the introduction about the world travel story, because Diane and I were 2 weeks ago in Seoul. We didn't quite recover from that one, and then the next few days later went to Berlin, and then just came in, just made it in time for trick or treat from Madrid last night. And so please forgive me for some lapses related to jet lag. I'm sure there will be some. So I'm going to be talking about opening a new era for the diagnosis and treatment of Alzheimer's. As Dr. Levine mentioned, that's not something that rolls easily off the tongue. It's a long time getting to this point to be able to consider this, that we made advances that make this new era possible. And I'll be talking to you about those and actually giving you a very live update, since the meeting I came from in Madrid is called CTAD, or Clinical Trials in Alzheimer's Disease, and so I can give you the very latest research that was presented there. We've been working for many years to develop better treatments and tests for Alzheimer's disease, and so we work with many companies, including the Alzheimer's Association, which we really appreciate the support and the collaboration. I can't say you'll hear throughout my talk today how highly I regard the work of the Alzheimer's Association. It's critical in making advances, and the association has really been in the vanguard. I'm so excited that the Department of Health up here, Department of Aging and Disabilities, or Disabilities and Aging, sees this as a priority. It really is. It's a really important problem, and so we need really help across the board. As probably everyone in this audience knows, because it's a meeting about brain health and Alzheimer's disease, this is a huge worldwide problem, and probably our least addressed major public health problem. So it's anticipated there will be 125 million people worldwide with dementia in the next 25 years. The cost of care is already greater than that for the cost of cancer and heart disease. It's a chronic disease. There's a high burden for families and for economically. And there's disparities, prominent disparities, where women have a higher rate, African people of color also have a higher rate. We don't understand all those factors, but it's really important. So, critical public health problem with an unmet need today. How did I get involved in this area? Now, I may get a little mushy part of today's talk will be to share the latest advances, at least as I understand them, but also talk a little bit about my personal journey in this field. I've been invested for more than 30 years, dedicated in this area, and also is going to be a Profiles and Courage theme about our research and highlighting some of our research volunteers who have made important contributions to the advances that you'll hear about. People often ask, how did I get involved in this area? And also often make the comment, you're doing God's work kind of thing. Maybe they don't mean it quite this way, but I think they're right. This is God's work, and that all of us are doing. I had a grandmother with dementia, and when I was a boy, and she had a long course over many years, and I got to see all the stages of her dementia. She even lived in my room for a time. We only had one extra bed in the house, so I saw very up close what the behavioral symptoms are like, the effect on our family. And so certainly that gave me a real sensitivity about this problem. And then growing up in the Jewish faith, one of the tenets is tikkun olam, that each of us has the responsibility for repairing the world, each in our own way. And so finding that, so as I was going into medicine, I thought I wanted to make a difference against a major brain disease. I was interested in brain health, brain function. And I realized increasingly how the enormity of this unmet need for Alzheimer's disease. And so that really motivated me, that combination. Now, I've been very fortunate to be able to share this journey with my wife, Diane, who is a clinical nurse specialist, and Diane has been the nurse coordinator of our memory and aging program. I said 28 years, she corrected me, she said 29 years. And we started this together with a few other colleagues, and it just grew into something way more important than any of us ever expected, fortunately. And Diane was largely responsible for that. And now she's become sort of a global ambassador for Alzheimer's disease, and we've taken trips recently to Australia and to Seoul, and Diane was a big hit. And it was obviously great to share that with her. But it's been great sharing this journey together in caring for patients with Alzheimer's. Now, thanks to the good work of the Alzheimer's Association, your advocacy arm, your lobbying arm, there has been a dramatic increase in NIH funding for Alzheimer's research. It was flat for a number of years at around $500 million a year, and now we're up at $3.8 billion. So a 7 times increase. And I think a lot of the advances have to do with that increased investment from the NIH and other and public-private partnerships. But the Alzheimer's Association worked really hard, has been working and continues to work really hard for that at the national level and at the state level to make this possible. We're still way under the funding for other major diseases, for cancer, for heart disease. We're sort of on par with HIV, but given the magnitude of the problem, you think Alzheimer's probably needs still continued funding. But I want to thank the Alzheimer's Association for leading the way in this effort, because investment is critical. What does it mean, the title of this talk? Advances have opened a new era for Alzheimer's diagnosis and treatment. Well, my goal really all along has been to treat Alzheimer's like other major diseases, like cancer or heart disease, that we make an early and accurate diagnosis with molecular confirmation. We institute risk reduction strategies and prevention strategies as they become available. And we have treatments that actually modify the disease course or delay or prevent progression. And what's really important in the Alzheimer's space and the dementia space is practical and coordinated care management that started early. Right now, as you know, care is very fragmented, and we don't do a good job at care. Our program, we haven't had the resources to focus on care, that piece of it, because we've been focused on the sort of the biomedical research side, but that is critical. And I know the association is certainly, in the Department of Health, I'm sure, and Department of Disabilities and Aging, very concerned about that. We can do better. I'll give a couple of suggestions. I'm not an expert in this area, but first of all, I'll tell you a bias. I am a huge fan of nursing. I think nursing and allied health fields like nursing, can do a lot. In terms, we can't mint enough specialists, dementia specialists at the physician level. It's unrealistic to even consider that. I mean, we should keep bringing good people into the field and certainly into research. But in terms of care, we have to really think of other ways to staff how we provide care. And there can be, in Sweden, there are dementia nurses in primary care. So when someone has a diagnosis of dementia, and they have occupational therapists too in primary care, then there's a staff member there that can start to intervene. There are care navigators. There's all kinds of creative ways that are going to be less expensive than trying to find physicians to manage care. All right, So again, this is going to be a high-level view. What happens in the brain? What changes in the brain in Alzheimer's disease? And this is a picture of Dr. Alzheimer up there, who was a psychiatrist, a very inquisitive clinician scientist. He was interested in a lot of diseases. He was interested in memory, schizophrenia, alcoholism, all kinds of problems. But he also ran a neuropathology laboratory, and some of the techniques that he developed we still use today are the hallmarks of Alzheimer's diagnosis. And his major contribution, we knew that there were plaques in the brain, but he described in his first patient, he only had 4 patients. Because why did he only have 4 patients? I said there's 150 million people with Alzheimer's disease. How come he only had 4? People didn't live very long. The average life expectancy was 50. And his first patient was actually early onset, was an autosomal dominant, a genetic form of Alzheimer's, as it turns out, a form of Alzheimer's disease. She was only 51 at the time. And he followed her, his first patient, for 4 years, and under the microscope, this is actually his drawing there in the middle, he saw these tangles inside the nerve cells. The plaques are in between the nerve cells, and the tangles are inside the nerve cells. Now, when he presented this data in 1907, he was ushered off the stage, shouted down, couldn't possibly be right. That's what happens when you come up with novel ideas. But they have stood the test of time, and we now know that the plaques are made of amyloid protein, the tangles are made of tau protein, these form clumps in the brain, and these are the hallmarks of Alzheimer's disease, and they remain the hallmarks, the pathological hallmarks of Alzheimer's disease. So they've stood the test of time, and I'll show you in a minute some of the advances we've made in imaging and detecting them now with blood tests. But when these clumps, first what happens is amyloid starts getting deposited in plaques 15 to 20 years before memory loss. So brain changes are occurring. That has some toxic effects on the neighboring neurons, which stimulates some inflammation initially, and then the formulation of the tangles made of tau protein. And it's when those tangles start to spread is when we start to see the clinical symptoms of Alzheimer's. The nerve cells are breaking down and their connections, and then in later stages the brain shrinks and really there's brain failure. It's the opposite of brain health. This is the end stage. You hear about heart failure, this Alzheimer's is brain failure. But it goes on over many years, and 15 years before the symptoms even start, and then probably 7+ years into the clinical decline. So, and you see this graph in the middle about when the amyloid occurs or when the tau occurs, and I'll show you some of the people that contributed to helping us so that we know that evidence, accumulate that evidence. So let's talk about some of the advances. So Dr. Alzheimer sort of laid the groundwork. Oh, one more very important point. So plaques, tangles, inflammation are key components of Alzheimer's disease. But there are Alzheimer's is a complicated disease. And aging is the major risk factor. There are genetic risk factors, and they're important clues. But aging is really sort of the foundation and the background of Alzheimer's. What's going on as nerve cells age? What happens to the energy production parts of the mitochondria? What happens to the breakdown and the clearance of these proteins and the programmed cell death and the metabolism? What happens with cholesterol metabolism inside nerve cells? These are all very important components of neuronal aging. And if we want to figure out the Alzheimer puzzle, the more we understand that, and that's why the funding from the Alzheimer's Association and the NIH is so important, to tease those apart, because new targets and new treatments will come from that. So fortunately, in Dr. Alzheimer's day, up until recently, you had to wait till someone passed away and look under the microscope to actually definitively diagnose Alzheimer's, to see the plaques and tangles. One of the first advances was in looking in spinal fluid, we could see small changes in amyloid and tau that was pretty predictive of Alzheimer's disease. So no, people don't like having a spinal tap, but there are clues and diagnostic markers in the spinal fluid that help, and there are now 1 or 2 tests approved by FDA for that. Then another major advance was brain imaging, using a PET scan with some of the same staining techniques that Dr. Alzheimer used, modified as a tracer for a PET scan. We can safely see the amyloid plaques, and well before the memory loss. So an amyloid PET scan is now, there are 3 tracers that are approved for amyloid PET, and then 10 years later, there's so far 1 tracer FDA approved for tau PET, but there are others in development. So we can actually see the plaques and tangles in life quite accurately and safely. So that's a major advance. Probably the greatest advance in biomarkers, and you've heard about this, are new blood tests for seeing very small changes in amyloid and tau, and those look really good. They were elusive for years. We had many conferences about them, but they all fizzled. But the technology improved, and we now, either with mass spec or with immunoassays, we can pretty reliably see the plaques and soon the tangles. We're working on that. We're pretty close with that as well. And some of these are actually coming into clinical practice. The FDA, I think, will approve the first blood test beginning of next year. There is a CMS code for that. They're working out the details. Right now, clinicians can order these tests, but they're not routinely covered, so the patients have to pay for them. We've been doing them through research, but we haven't been ordering because it didn't seem fair. Fortunately, the PET scans were also, even though they were a terrific advance, were not covered until recently, until the first drug that was fully approved by the FDA, lecanemab. Now, since then, the PET scans are covered as well. So I just want to give a shout out to a couple of the people that have made a big difference. These are just examples of really the courage and the generosity of our research volunteers. This is Maritza Siliberto and her husband, Rick. Maritza has many roles. Her mother had early onset Alzheimer's disease, so she's been a caregiver. She's been an advocate. She's participating in a very important study called the Dominantly Inherited Alzheimer's Network, or the DIAN study, for many years. And has been very courageous there. And she's also worked for the Alzheimer's Association and as an advocate. I think she's on the senior council of the NIH, advising the NIH of how to allot research funds. So she's plugged in many ways. And in addition, which is amazing that she's able to do this, she has other roles. She is the mother of 3 boys, a pair of twins and an older son. And she has been the principal of a school for the deaf in Boston. And she just, a few months ago, earned her doctorate. Earned her doctorate in education from Northeastern. And she was very, very proud of that. So we're very proud of her. She's a terrific person. But those curves that I showed you came about from the DIAN study, by studying family members who we know are going to get Alzheimer's because they have a mutation. You can start studying them at age 18, and from that you can derive the curve. So when amyloid starts to accumulate, when tau accumulates, when the MRI changes, etc. So it's hard for me to communicate how difficult it is for someone like her to participate, because coming with a family with early onset Alzheimer's disease, she always had to face the idea, is she affected or not? Just coming for visits, having testing done, it was really a challenge. She had some complications from spinal tap. She still continued to get them. We figured out a way to work around it. Just very inspiring. And that's been probably the most rewarding thing for us, and I know Diane feels the same way. No, I know I'm going to get mushy on the next one. I always do. Well, it's really impressive what the FDA required for approval of PET scans for Alzheimer's. So they required that people who are terminally ill go to the hospital, have a PET scan, and then when they died, they donated their brain. And we compared what we saw on the scan with what we saw under the microscope. So these were people at the last days of life. And when Diane and I started out doing these autopsy studies, we went to people's homes. This is Mr. Kelly, a Korean war veteran, who had late-stage Alzheimer's disease, and he was very frail. That's a picture of him in bed. He was bedridden, really, with Alzheimer's. And we said to his wife, Del, are you sure you want to do this? He's so frail. You really want to put him in an ambulance, take him over to the hospital, go through this whole thing, donate his brain and everything. And I won't probably be able to communicate this to you, but she said, don't think another thing about it. This was, he wanted to make this his last contribution to science. And he didn't want his children or grandchildren to have to suffer with Alzheimer's. So just really terrific contributions. And I was fortunate to be the senior author on this paper that led to FDA approval of the tracer that he tested. So he got his wish. Okay, so people often ask, always ask, not often, always ask, what's the difference between Alzheimer's and dementia? For some reason, people conflate those two. And the answer is that dementia is a general term that means that there's cognitive difficulty that interferes with day-to-day functioning. And it doesn't describe the cause. Alzheimer's is a disease, which I showed you, made up of plaques and tangles and other changes in the brain, which is the most common cause of dementia. But there are 100 causes of dementia, Alzheimer's being just the most prominent of the group. And often Alzheimer's co-occurs with other factors that contribute to dementia, like vascular disease. So what's involved with the evaluation for cognitive impairment? Well, people often ask, should I even find out? And there's a lot of nihilism still about Alzheimer's. We're in this transition stage where it's increasingly being viewed as a treatable illness. I wouldn't say that's the prevailing view at the moment. And also the whole concept of brain health, although it's gaining in prominence, is still a nascent idea, which we have to bring forward. But it's very helpful, when someone is having cognitive decline and it's interfering day to day, people are very confused what's going on. So it's helpful to know if there is an underlying, if there's a primary disease process causing it. And people need to make important decisions about work, driving, financial planning, need to get educated about the condition, what to expect, how to manage it, get connected up to the Alzheimer's Association, to a geriatric care planner if needed, adjusting the daily routine, obtaining resources, and then finding out about treatment options, either those that are currently available or are being tested through research. Now, in terms of the evaluation, even though we have new diagnostic tests, I mentioned to you about PET scans and blood tests and so forth, still the diagnosis is based on a careful history from the patient and family members who know the person well. And then determining, is there cognitive impairment or not? What's the degree of it? What are the features of it? Is it likely due to Alzheimer's or something else? Is there a neurodegenerative process or not? And then we can do additional testing to sort that out. But the history is very, very important from someone who's knowledgeable about it. Now, increasingly, we're going to be faced with the opportunity to get a blood test to determine if there are Alzheimer changes in the brain. I think we're very much in a transition phase here. Soon, as I mentioned, there will be FDA approval, there will be coverage, and then there will be access. Then we'll have to figure out, okay, how do we use this in clinical practice? Again, the same principle applies. Doing a careful evaluation to determine if there's cognitive impairment and whether or not Alzheimer's is a likely possibility. And then an MRI scan is important to look for signs of Alzheimer's, look for signs of other conditions that could be causing cognitive impairment. Fortunately, we're at a point, even in the best hands, a clinical diagnosis is wrong about 25% of the time. We say it's Alzheimer's, but it isn't Alzheimer's, it's something else. In primary care, it's more like 38% of the time. So, but fortunately, we're living in an era, or soon be living in an era, we can confirm it with a molecular test. Yes, there is Alzheimer pathology, or no, there isn't Alzheimer pathology. And if it's no, it's unlikely to be Alzheimer's. And if it's yes, it's likely certainly to be a contributing factor, if not the main factor. So that's a big change. But again, it doesn't replace careful history taking, and there's a lot of challenges in rolling this out. Primary care is not used to doing this type of testing, and if they do, then what's the next step? Once they make a positive diagnosis of Alzheimer's, are there referral centers for them? Usually there's a long wait to get in to see a specialist. This is a real problem in terms of our healthcare system. And then the question is about what treatment options are available to patients once we make the diagnosis. Well, I think on the practical side, for all patients, especially with cognitive impairment, this is a really bread and butter for the Alzheimer's Association, is really to focus on the basics. People need to have the right level of support. Probably our most distressing cases are people living alone without a lot of family support, and they're declining and failing. And it can be a failure to thrive situation where we wouldn't let a child be in that situation, but we let an adult be in that situation. It's terrible. So we want to try to find the right level of support for the person. Education for the family about how best to manage it. It's not easy because the person has changed, the relationships are changing, the finances are changing, so many things are changing, so much stress. And it may be a child who's the primary caregiver, and she's got her own family to deal with. There's so much caregiver burden, so many issues to deal with. So we need to help with that to the best we can. And then we tell families, this is a little mnemonic that one of our neuropsychologists developed called meals, wheels, bills, and pills, which is real practical, is making sure they're eating well, there's driving safety, their bills are getting paid, they're taking their medications as prescribed, and they're not too isolated. So this is really important basics. The other real important one day to day is not arguing with the person. If they insist something occurred a certain way, and it may not even be rational or reasonable, find ways to diffuse that rather than trying to take it on and win the argument. You can never win those arguments. So that's something family members need to learn. Then what treatments are available, either currently approved or through research? Well, we've had 2 oral medicines, cholinesterase inhibitors and memantine. Donepezil used to be called Aricept for some time. And they're approved for the dementia stages. For Donepezil is approved for all stages of dementia, and memantine is approved for moderate to severe dementia. Those 2 are not approved for mild cognitive impairment, the lead into dementia. We have 2 new treatments, which I'm sure you've heard about, called lecanemab and donanemab, that lower amyloid plaques. They are approved for early Alzheimer's disease in patients that don't have significant safety concerns that are good candidates to receive them. And so that's a new option for patients and families to consider. Now, just talking briefly about these new medicines, we know amyloid plaques play a big role in Alzheimer's disease. They're not the only part, but an important part. And these medicines, this class of medicine, is able to remove amyloid plaques from the brain to a very high degree. So this is looking from the lecanemab phase 3 data. After 18 months, there's a substantial lowering of amyloid plaques, and the majority of people are now considered negative for Alzheimer's disease. They go below the cutoff. So this is a real advance. We've been testing these drugs, and we were sort of leading this effort for many years, different compounds that lower amyloid. But these are the first that actually lower amyloid to this degree. And the other ones, we didn't really get a clinical benefit. And it looks like you need to lower amyloid below a certain cutoff to see a clinical benefit. And so fortunately, these two drugs are able to do that. And what are the benefits? This is looking at both lecanemab is on the left and donanemab is on the right. They're not compared head to head, so you can't say for sure one works better than another. They both work similar, I would say a similar effect. I would call this a mild benefit. And the benefit is, as a group, there's a slower rate of decline in people who got the treatment after 18 months than people who are on placebo. Now, I think I have another slide coming up next about that. Maybe donanemab has a slightly greater effect, but it really is not compared head to head, so I really can't say that. But there can be a slowing, and the main clinical significance of this, and the main reason to consider using it, is it delays the time for moving from one stage of dementia, so from mild cognitive impairment where the person's pretty independent, to mild dementia, or from mild dementia where someone needs more help to moderate dementia where they need a lot more help and starting to become disabled. It delays that time. So people stay in a milder state of Alzheimer's longer where they're independent with better quality of life. So that's what most of our patients who come to see us want. They don't want to, it's really the later stage of Alzheimer's where people become dependent and lose their whole sense of self. That's the greatest fear. And so they want to be able to delay that or preserve their quality of life for as long as possible. I would consider this as an entry-level treatment. This is just the beginning. I don't see this as the end game. This just gets us started in disease modification. We have to amplify this effect. I think this is a meaningful effect. There's a subset of patients who actually do extremely well, and I'll show you an example in a minute. Oh, we're coming up next. So we studied aducanumab, another drug that's approved by FDA, but it's no longer being developed. It was very controversial, as you probably heard. It's being retired from clinical use today. Biogen decided they got an accelerated approval, not a full approval, and since that time they were doing another placebo-controlled trial. But since that time, lecanemab and donanemab came along, and they decided it wasn't commercially reasonable to keep developing the drug. So that's not really available. But we tested this for 9 years, this drug, and I was actually one of the lead study leads for this program. And we had a subset of people, and this is an example of one person, another great person I want to give a shout out to, who was on aducanumab for about 7 years, and for about 5 of those years didn't decline. He stayed in the mild stage, lived a full life, drove everywhere, very, very verbal, outgoing guy, went to all his places and carried on his lifestyle. And he felt good, his family noticed it, we noticed it, he didn't decline on his testing, and that's a great response. And we had a subset of people like that who had even better than what I showed you from the trial as a whole. So there may be some responders who do even better. And his story, this is Neil and Maureen Corkery, same thing. Not only was he a tremendous research volunteer and contributed a lot, even up to the time when he passed away recently, donating his brain so we could see what the effect was of that treatment over so many years. But he was willing to share his story on the front page of the Providence Journal. When we launched, we were the first to give aducanumab once it was approved by FDA. He came to that press conference and spoke about his experience. And he also had recovered from substance abuse. He was a strong advocate for that, too. So he amplified his contribution, not only as a research volunteer, but as an advocate. And that is so important. And we talked about this just briefly before the program started, about communications and awareness. Telling these stories, people sharing their story, is powerful. And we need that, because we're really changing the narrative about Alzheimer's, moving it from untreatable to treatable. And we need the stories to help move that forward. And we're so grateful to Neil and his family for being generous about that. Now, any medication has side effects, and I don't know, I wouldn't say I'm proud to say, but we were the first to report the main side effects from this class of medicine. We didn't know. When you test a new type of drug, you don't know what the effects will be. Well, it turned out, when you remove amyloid plaques from the brain, you can get fluid shifts in the brain. And you can get swelling, brain edema, and you can get leakiness of blood vessels to blood products as well, usually microhemorrhages, but it could be a more serious hemorrhage. And it turns out that when you lower plaques, at least up till now, and I'll show you a new treatment that's coming down the road, if you lower plaques substantially, you'll get this side effect. It's called, and we've given it the name, amyloid-related imaging abnormalities, or ARIA. And 75% of the time, it's asymptomatic. It only shows up on an MRI scan. The patient doesn't know, the clinician doesn't know. So you need to have regular safety MRIs. It tends to occur early in treatment. It's usually transient and manageable if it's carefully done. But we need MRI monitoring, especially for the first 6 months. Occasionally, there can be symptoms, and usually they're pretty nonspecific: headache, dizziness, unsteadiness, confusion. The confusion could be very hard to separate from underlying Alzheimer's, visual disturbance. And I'm sure you've heard that there can be more serious cases, and that's what gives us the most cause. And there can be severe edema, there can be a fatal hemorrhage, and there have been a number of fatalities related to treatment. So we've developed the guidelines to help mitigate that to the degree that we can. But patients and families need to weigh out whether or not the treatment's right for them. Are the benefits worth the risk? And then each person's risk is a little different, which I'll talk about in a moment. So this is just an example here of the brain edema. And that's in that MRI on one side of the brain. It can be really subtle, like just a tiny amount. There can be, over here, microhemorrhages in that third panel, the little black dots. That's, again, leakiness to blood products. Or there can be a little bit of lining of blood products in the meningeal, in the covering of the brain. How do we mitigate this? Well, it's very important. And who's an appropriate candidate? Who's an appropriate candidate, and how do we mitigate this side effect? As I said, these drugs are approved for people with early Alzheimer's, so mild cognitive impairment or mild dementia. The mini-mental state range for lecanemab was 22 to 30 in the trial, so that's the range they were using in clinical use. They need an amyloid test, either a PET scan, a spinal tap, or possibly a blood test. They need an MRI scan to make sure they don't have safety concerns. If they have what's called signs of cerebral amyloid angiopathy, more than 4 microhemorrhages, any area of superficial siderosis, that's that lining of the covering of the brain, severe white matter changes, too much cerebrovascular disease, then they're not good candidates. So we need to carefully review the MRI scan at baseline. They need something new. Another big risk for this, the edema, is a gene called the ApoE4 gene. And so in the prescribing information, it says that ApoE testing should be performed to inform the patient's risk and to help with management prior to initiating treatment. So that's something new for Alzheimer's care. We've been doing this for 15 years, ApoE testing routinely. It's gone extremely well, but it's something new for the field. So some of our colleagues will probably need help in this transition phase. There was a slight risk of intracerebral hemorrhage, brain bleeding in patients who were on anticoagulation with lecanemab. And as a result, we've recommended not treating patients who are on blood thinners like on strong blood thinners. They can be on aspirin or other antiplatelets. Can we use AI to detect ARIA? Now, one of the advantages in the clinical trials is we had expert readers, a central reader who had read thousands of scans, and they were great at detecting ARIA, and we could really rely on those readings. When we go into clinical practice, we're going to have a handful of radiologists who are familiar, but many who are not. And I think we should be able to use an automated software program based on AI that's smart, a smart program, that actually can detect these changes quite in detail and guide the radiologist and the clinician. It's going to be a challenge. This is actually a public health issue, but how to get the, we're working with some companies who are developing these software programs, so they look great. The trick is getting them into practice, and that's going to be a challenge. I haven't figured that out yet, how we're going to do that. But it could really help. It's going to assist the radiologist. It doesn't replace the radiologist. It's going to assist the radiologist and the clinician. Okay, another big challenge. Are the treatments covered? Is the testing covered? And this is a work in progress. Fortunately, this was huge, and the Alzheimer's Association really went to bat to make this happen, is getting coverage for these two new medicines. And as a result of the lobbying that many of you did outside Medicare offices, in the Congress, in the Department of Public Health, in Health and Human Services, in the White House, in the state legislatures, Medicare agreed to cover these treatments and the testing, supposedly, that goes along with it. They're not even sure what they're covering, but because I've been working with the Medicare. Like APO, I say, do you cover ApoE? We're supposed to be. Well, they don't even know. But anyway, it's a huge step forward that they agreed to cover, and it took lobbying. And you might have seen, this is not true around the world. In the UK, their FDA, British FDA, approved lecanemab. They put some restrictions on it. They don't allow treatment of E4 homozygotes, people at high risk of this ARIA, but their health system doesn't cover it. So they got their FDA approval, but they don't have coverage or access yet. It requires private pay. That is a no-go, as far as I'm concerned. Whoops. We need parity in terms of new treatments and tests. Whoops. New treatments and tests for Alzheimer's. Okay. So this is a work in progress also with each private payer, Blue Cross and the other, United and the other private payers, to see if there will be coverage. Now, again, I already talked about the Alzheimer's Association with the lobbying, and then same thing about the advocacy from the patient side. This is another study volunteer, Stephen Blaze, who's been very public. His mother was the first person, one of the first people we saw from a very large kindred, 100 affected family members with early onset Alzheimer's with a mutation in one family, one large family. They themselves, one single family might help with the diagnosis and a cure eventually for Alzheimer's disease. Well, not only has his family been terrific, but he has been an advocate, fundraiser, and also he's become a marathoner. And he's completed, this was a recent piece about him, the 6 leading world marathons in New York and Paris and Tokyo, and did it all in the memory of his mother. It's just a really amazing what people can do. And I think one thing I attribute our success to is that we created a program, and I think it came from the mom-pop operation that we had and Diane's nursing background. We have great nurses in our program. We always put the welfare of the patient first. We're obviously interested in science. We want to move the field forward, but always putting the welfare of the patient first. And people knew that, and I think that inspired them to do great things themselves, which is awesome. I mean, so we just have fed on each other. It's been terrific. It's been so rewarding. Again, talked about prevention. Dr. Levine mentioned about the possibility of prevention. Diane helped launch the first prevention trial for Alzheimer's called the A4 trial. This is our first, we were the first in the world. This was our first participant. And front page of the Providence Journal, we had a small infusion suite at that time, and we just had news crews from around the world just cramming in there to cover. And Peter Bristol, our first patient, was willing to go forward and share his story. Huge. Just amplifies, what we can do together. All right. Can we prevent Alzheimer's? Well, we sure hope to God that we can, right? You heard from Dr. Levine about cardiovascular disease. We made a lot of progress in cardiovascular disease and lowering the morbidity and the mortality rate. How did we do that? Well, we came up with risk modification strategies, which have proved to be quite effective, and also acute treatments for heart attack and for stroke, and that's lowered the rate of both of those conditions. So we were inspired by that. And the Alzheimer's Association has matured, and not only is a funder of research, but now is a collaborator in research. And so you heard about from Howard that roughly 40% of dementia risk may be modifiable, primarily through lifestyle factors. And there's data from the FINGER trial, which was conducted in Finland, of a combination trial of exercise, a Mediterranean-type diet, a good heart health, and brain stimulation and social engagement in improving memory in people at risk for Alzheimer's disease. And the Alzheimer's Association undertook a companion trial, expanded on that, called the US Pointer Trial. And we're fortunate to be selected as a site for that. There are 5 sites in the US. And the way the program is structured is that there's a memory program like ours. There is an intervention program that helps implement these different treatments. One group is self-guided. They do it on their own. They get some education. And the other group is very actively guided with much more intensive involvement from experts at lifestyle modification. And then the other partner is the Alzheimer's Association. Alzheimer's Association actually hires staff as navigators to be part of that intervention. So not only are you funding the program, but you're also staffing it as well. And so we just had a beautiful partnership. It's been a great success. We didn't know we were expected to enroll 400 people at our site. That's the most people we ever enrolled for a trial. We didn't know if we could do that, it's being a small state. We did. Diane didn't think we would, but she said, "You're nuts to do this one." But we did, which was that in itself was terrific. And now we'll wait until May, and we'll get the readout from that 2-year trial on this combined lifestyle intervention. It's just been a great partnership between our memory group. We have a cardiovascular group, a cardiovascular health group, and the Alzheimer's Association at our site. Across the country, another big mission was to enroll people from underrepresented groups. We enrolled, I think, 33% of the population is from an underrepresented group, which is a lot. for clinical trials. We're very, very happy about that. We came up with all kinds of new initiatives for doing that, working with faith-based groups and community groups and really expanding our reach, which is terrific. And I'm happy to report that a whole new network has formed called the Worldwide Finger Movement, where the Alzheimer's Association is a key player, and now in 6 continents and 70 countries, this type of research is going on, and we're working together and trying to pool resources. So I am confident in terms of the prevention side. If we can promote, I'm going to say to me what the strongest arm of this intervention, if we can promote heart health, we keep people heart healthy, their brain is going to stay healthier, the rate of dementia and Alzheimer's is going to go down. That's something we can do worldwide now. And so I'm really excited about this. This is totally in the public health, Department of Health, domain. And I mentioned about, it's another key priority to test treatments and diagnostic tests and interventions or do observational studies in patients from a variety of backgrounds. And that's going to require a real commitment. And the NIH is finally getting behind this. They've given us mandates for years, but no support. And now finally, there's the support that's coming along with it. And also, we need a lot of creative ideas. Again, when we launched our faith engagement model for US Pointer in the New England site, we had a press conference at the State House and brought together leaders and again publicized that. We're sort of like news hounds, hogging whenever good press we could get and just getting the message out and changing the narratives. And it had a huge effect. We sometimes call it the Neil effect, about what Mr. Corkery did. Many people came in, I read about Neil, I heard from Neil, I met Neil in the coffee shop. He said, you got to come in. But what happened was there was a perception over time that something important about Alzheimer's was happening at our hospital, and people wanted to come. So that came from all these different stories that had that effect. Okay, I mentioned earlier about the workforce and how to make a difference in care. As we get these new treatments, we really haven't figured out how to deliver them yet, or the diagnostic tests, or especially a coordinated care model for Alzheimer's. Primary care is the guts of medicine, and they have to become very actively involved, both in clinical care and research, and rolling out new treatments. Now, I don't know if you saw the story last week. It was a large retrospective simulation trial of type 2 diabetics, and they looked at people who got semaglutide, one of these new weight loss and diabetes treatments, and who got other treatments for diabetes. And it turns out the rate of Alzheimer's was like 33% in the patients who got that GLP-1 agonist, that medicine. Now, if that were to pan out, there are 2 phase 3 trials with that drug that have been enrolled, and in a year, we'll get the readout from that. If that works, so far that drug has worked for everything, but if that works, that would be huge. 1, it would give us a new treatment option, but 2, it would bring primary care right into the center of this, because they know how to use this drug, and we need them. We can't do this on a large scale. We can't scale all these advances that I'm talking to you about without that segment of our healthcare system. But that's not enough. It's not fair to ask primary care to take on more. Every primary care provider is probably stretched to the max in what they can do. When you put in a diagnosis of Alzheimer's, that takes time. You got to talk to the patient, the family, the resources. It's a lot of care. And the primary care doesn't have time for that. So how are we going to do that? I mentioned we have to expand our workforce. We have to be creative. We have to fund it. It will work out in the long run. I'm not a health economist, but I am a devoted clinician. I think we can work this out. Dementia nurses, nurse practitioners, care navigators. Care navigators don't have to be, they can be paraprofessionals. Just like in cancer care, In many comprehensive cancer centers, you get diagnosed with cancer, you get a care navigator. There's a lot goes on with the care for cancer, and you need help. We need care management plans. This is definitely a Department of Health and a payer approach where we come up with reasonable ways to approach patients in a systematic kind of way. And then we're getting so much information from our personal assistants, from remote monitoring, and that we could apply both to research and for clinical care. We have to harness that power. Okay, I said that the new treatments are a good start. They have their problems, which I was pretty clear with you about. But can we do better? Can we enhance effects? Can we come up with new treatments or combinations to have a bigger impact? Well, I'll share some data that was just presented 2 days ago at the conference in Madrid. One of the problems with these treatments that lower amyloid or with any large molecule is that the brain has a barrier called the blood-brain barrier that keeps large molecules out, protects the brain. But if you want to get a medicine in there, it ain't easy. So is there a way to get, and these antibodies, donanemab and lecanemab are large molecules, can we get them in at a higher concentration? Well, there are different technologies being developed. I'm sure this is going to pan out. This is an example of a brain shuttle where you use another molecule that can get in to the brain through the blood-brain barrier, and it combines with the antibody, and you sneak it in through this technique. And it turns out one drug that didn't work, that didn't quite meet the clinical outcomes, an amyloid-lowering treatment called gantenerumab, it's now being combined with this brain shuttle technology, and you can get from 1% 20% into the brain, a major increase. And so far, we'll have to wait and see how it pans out, there is amyloid lowering after just 2 doses. 90% are amyloid negative after 2 doses, and so far they have hardly any ARIA. That main side effect, it looks like the uptake pattern is different. The main problem with what causes the ARIA, the leakiness, is that there's amyloid in the blood vessel as well as in the brain. And when the antibody binds to that amyloid in the blood vessel, it opens that blood vessel wall in some patients, and they can get leakiness. The theory with this is you get this, you bypass that arterial binding to the amyloid in the blood vessel, and it gets into the brain itself. So it produces a much lower rate of ARIA. So we'll have to see, wait for the clinical outcomes, wait for the more safety data, but really encouraging that we can find other ways. And you can imagine applying this brain shuttle not just to these drugs, but other classes of medicine to get higher concentrations and bigger effects in brain. And also combining treatments. So I mentioned to you that there are many components to Alzheimer's disease, amyloid being one of them, tau being another one, and there are many treatments that are targeting tau. One of the things treatments I'm most excited about is a gene-modifying treatment. So this is called, and all has funny names, called an antisense oligonucleotide. And what this does, right now we have to get, one of the challenges, we have to give this medicine in the spinal canal, intrathecally. The current dosing, we don't know the right interval, but it's every 3 months. So far, it looks like that medicine it interferes with the mRNA message, and it keeps the tau from becoming a tangle. It keeps the tau from going into, so it blocks tau from its pathological form. And so far, it looks like, in the early days, that it lowers the tau signal on the tau PET, and it may have a cognitive benefit. So we're waiting for that to read out, but I'm very enthusiastic. This has worked for other neurologic diseases that had no treatment. One called spinal muscular atrophy uses an antisense oligonucleotide. This would be awesome. So, and there are a number of treatments just at this meeting targeting tau that showed some good preliminary data, but there's so many other targets in the brain that might be, I mentioned about the anti-inflammatory, the semaglutide. semaglutide that's used for diabetes and weight loss. That's just another example. Okay, so what might the future look like for Alzheimer's disease? I'm hopeful that will be early and accurate diagnosis. We won't wait till people are far into the disease course. We want to institute a healthy brain lifestyle, and we'll be gaining more information about that from these different trials, US pointer, worldwide finger studies, to guide that healthy brain approach. But all of us should be doing that, starting as early as possible in life and keeping it up. It's like common sense, but hopefully it gives us brain health, gives us more motivation. Another reason, not just heart health, another important organ to keep healthy as we age. I'm hopeful. The problem with some of these treatments that I described to you, I think these are so exciting and so amazing that we're even contemplating them. But it'd be hard to scale this worldwide. These are expensive. They require infusions. They might require PET scans, MRI scans. This is not available all around the world. So I think there may be other approaches that are more scalable, such as could we do a large-scale screening study as we have better diagnostic tests, blood tests, and vaccinate people against amyloid and tau. Just give a couple of doses and keep those who are at higher risk, keep the plaques and the tangles from ever forming. Will the amyloid treatments that we're now testing work for people at risk for Alzheimer's who are building up plaques but don't yet have symptoms? There are 2 large-scale trials underway. We'll find out in the next couple of years. And that's why we're so appreciative of the Alzheimer's Association and the NIH. We need new discoveries, combination treatments, and certainly much better coordinated care. So I think, in summary, we've entered a new era for diagnosis and treatment of Alzheimer's. A lot more work needs to be done, lots of stigma still. We need better tests and treatments, and we need to advocate to get them covered, build the workforce for better coordination of care. And this is, I think, hopefully if this didn't come through, then I really failed. This is a partnership of love, faith, and science that we undertake together. I'm so glad the Department of Health is here. I was invited to give a keynote to the World Dementia Council over in Amsterdam, and we had the Prime Minister of the Netherlands was there, their Director of Health was there, their Health Commissioner. We had some Amsterdam researchers and Mia Kivipelto, who was the PI of the finger trial, the lifestyle trial. So it was terrific. And actually, they had a concert in the middle at the intermission of the meeting of patients and researchers. It was a beautiful concert of instruments and singing, a chorus, to accompany the meeting. So thank you very much.
I'm just going to thank you. And you're going to be here for a little bit longer. So do we want to take a little time for Q&A and push back a little bit so we can have a couple quick questions with Dr. Sattaway here? If folks have something from that amazing presentation that they're burning to know more about or clarify.
Yes.
Are some of the lifestyle changes that you're talking about, do they include sleep?
I hope not.
Ever since residency. Sleep's important, actually. It may be a clue in a few ways, biologically and also clinically, that some of the first changes may be in sleep. Either sleep symptoms, like active sleep, which could suggest a condition like Parkinson's or dementia with Lewy body, people are acting out their dreams, or just having insomnia or fragmented sleep. Turns out people who sleep better, so if we can figure out how to sleep better as we age. It's to our advantage because there's better clearance of amyloid when there's sleep. So if people don't sleep, they are a little bit more at risk. So yes, sleep is an important parameter. Yeah.
I get residents with diagnosis of Parkinsonian dementia and others with Lewy body. Is there a difference or?
Oh, that's a great question about the difference between Lewy body and Parkinson's dementia. That's actually a source of debate. Primarily, there are other things that can cause Parkinson's that are not Parkinson-like, which we call Parkinsonism. But let's put those aside. There are some conditions like that. The main protein that builds up in Parkinson's is called alpha-synuclein, and it forms a Lewy body. It forms that clump. It's called a Lewy body. Dr. Lewy described it. And so all patients with Parkinson's disease and dementia with Lewy bodies have Lewy bodies. So it's a disease that's called a synucleinopathy. It's a disease of alpha-synuclein. And some patients present, so what we call the phenotype of the clinical presentation varies. So for patients with Parkinson's, the typical presentation is tremor on one side, a rest tremor, and a tremor on the other side, and a stoop posture, and a slowing of gait, and a slowing of thinking. That's Parkinson's disease. They have Lewy bodies. Patient with dementia with Lewy bodies may present in a variety of ways. Some first with sleep, when they have active sleep. They may have Parkinson's or not, Parkinson motor symptoms, but they get dementia. They have cognitive impairment, they have behavioral symptoms. So it's some overlap.
Okay, so they don't necessarily have the Parkinsonian symptoms with some of the Lewy body?
No, you can have dementia with Lewy bodies without any motor, any prominent motor. They may have some if you test carefully,
Yeah.
but not prominent.
Okay.
Yeah, so it varies. Yeah.
Thank you for your presentation and your research. It's very helpful. My question is, I know that depression and mood disorders are often a risk factor, and I'm thinking the correlation would be just the social engagement and learning, but I was just curious to hear more about that.
Yeah, that's another one, again, a clue. All these things are clues, things that's sort of line up as a risk factor that sort of make the cut when you carefully evaluate. Depression's on that list. And again, I think it can be a marker. Some people, the first symptom of their Alzheimer's is depression. They come in with depression. And they may or may not have memory loss, and the memory loss may come a little later, or sometimes they co-occur at the same time. But depression, and usually in the case where they're co-occurring, you treat the depression with a medication, but they still have the cognitive difference. It doesn't treat the cognitive problem. So I think we need to understand that way better and how depression is a risk factor. Certainly there are social aspects to it. People who are isolated don't do as well as people who are engaged in terms of their day-to-day function. And they may be more depressed as well. So that's another component to it. But I think there's a biological component to the depression, and that we need to understand better. Yeah.
I was wondering what your thoughts were about the link between oral pathogens, oral disease, and brain health, and whether that warrants addressing oral health as a risk factor.
That's a great question. These are all great questions. Yes, of course. Well, first of all, promoting oral health is a good idea. Why not? Okay. But there is a relationship between oral health, between the flora in our gut, and Alzheimer's. We don't understand this well yet, but it's a really growing area of research. US Pointer has a sub-study that actually looks at that, not the oral health, but the gut health. So yes, we should promote good, that's something you could do, good oral health. But understanding the mechanisms is really important too, so that we can guide interventions. Yeah.
Sorry to interrupt. Can you use the other mic? I
Sure.
just
I'm
have
sorry,
a lot
I
of people
forgot about
joining
that.
live stream, so that's good, but they can't hear your responses.
No,
Thank you.
Sorry.
If you could just make a couple comments about, well, like intellectual activity and spiritual activity, and then also like substance use like alcohol, tobacco, marijuana. It's a lot.
Okay, all right, all the ancillaries. Well, there's different ways to respond to that. One is certainly when you're doing a clinical evaluation, you want to know about substance use because often that can be contributing to the cognitive impairment. So if someone is a heavy drinker, for example, alcohol has toxic effects on the nervous system, especially high use and long-term use. It can cause dementia on its own if it's, severe enough, where the person's susceptible to the effects of alcohol. So that's one thing we have a subset of patients come in with Alzheimer's, let's say, but also are heavy drinkers too. And we really counsel them, ideally to stop drinking, but certainly cut way down on their drinking. We usually do one and done, or none at all. But so reducing alcohol use in someone who has cognitive impairment is a good idea. We often tell them that's one lever, one dial they can control. There's a lot of things you can't control about Alzheimer's. That's one potentially modifiable. So that's one. I'm sure other drugs that have potent effects in the central nervous system could also have negative. Certainly, one of the main things we do in good medical care is screen for medicines that are contributing to the cognitive impairment and trying to eliminate those if we can. So yes, both substance use and other medications can cause dementia, actually, or contribute to it. Marijuana, I don't know, what the long-term, depends how much marijuana use there is. Again, I would advise someone in the same way, just common sense, to limit the marijuana use if they had dementia, if they had Alzheimer's, a diagnosis of Alzheimer's. But that needs to be studied a little more carefully, that relationship there. Social brain stimulation, we think the brain is built for stimulation. That's how we maintain our vitality. And so staying stimulated and having ways to stimulate the brain continuously as we age and being engaged in things that are meaningful to us is really important, I think, for good brain health, for good health, good well-being. So all these things are practical. I don't know if I answered all the ancillaries. I had a few. I don't know if I gave you the answer you wanted either. But. Yes?
Regarding learning new things, I heard, that learning a new instrument, that music is one of the best learnings that you can do for your brain.
Yeah, so again, keeping the brain stimulated is a great idea. And there's actually animal work on this, that animals that are stimulated as they age have much more vibrant neural networks than animals that hang around and don't do anything. They have controls and actively stimulated animals. So there are a number of things we can do, playing music, learning an instrument, singing, and so forth, learning a language. It's harder to do when you're older than when you're younger. Our brain is much more facile when we're younger and a little more resilient. But it's absolutely a great thing to do. And being engaged with other people while doing it, too. In the back. Oh, yes, sorry.
I really appreciate your attention to humanity and sharing stories as well as the research. And I wonder if you could speak a bit about questions of ethical considerations and practical considerations and gathering and documenting stories of people.
Yeah. Well, I'm not an expert in that, but obviously people have to be, it's voluntary. They have to be willing to share their story, and that takes a lot, especially with the stigma about Alzheimer's, to say you have Alzheimer's or you're at risk for Alzheimer's or whatever the situation is. Usually it comes from people who are really motivated to make a difference. They want to maximize what they do, and that's why they participate in research, but they're also happy to share their story because they see the value in that. And so they have to sign consent if they're speaking with the media and so forth. So yes, the ethical part is very important. There can be no coercion whatsoever. These are people who volunteer. But increasingly, the Alzheimer's has its own, I don't know if you have one here in Vermont, the Patient Advisory Board. Certainly the National Alzheimer's has that, and people are willing to, and it's great, because often you need to speak to the FDA or the NIH or somebody, or a new development comes out, they're asking for public comment, and it's great to have people like that who are knowledgeable, who are themselves engaged in this and at risk and concerned and willing to share. So, yeah, but you certainly have to be careful about it.
Thank you so, so much. That was the perfect segue. We just so deeply appreciate all that you've given to us today, you and Diane, as well as to Alzheimer's and dementia and to the world. So thank you for making the trip to beautiful Vermont. And Dr. Salloway will be with us through the break. So if there were some questions that we didn't get to, you can try and find him or his wife at the break and ask them. So my name's Meg Polite. I'm the policy director at the Alzheimer's Association. And I said to him, that's the perfect segue, because a lot of what I do is really work with people who are interested in telling their stories and then identify who needs to hear that story. One of the things I loved about your presentation was you did weave in the heart and the humanity with the science, and the way that the Alzheimer's Association has been so effective in getting those additional funding dollars and expanding what we're doing. A lot of that has been because we've balanced the actual human impact and the human voice with the scientific data that says, yes, this works, yes, this is safe, yes, we need to do this, this is worth an investment. So I would love to talk to anybody here who has people that they're working with that are interested in amplifying this. And one of the things that Dr. Salloway mentioned that I hear a lot, well, two of the things, one, the person with dementia really wants to do something of value where a lot of what they can do has changed. And something they can still do that has value is to tell their story and speak publicly. And the other is that they're really thinking long-term, long gain, and they want to make sure that their children, their grandchildren, their friends and their neighbors don't have to go through what they went through. So thank you for raising those points. And I also just wanted to really thank Dr. Levine and also Dr. Bowen, who's not here, who's the Commissioner of Dale, for the work that they do. I work very closely with members of the Department of Health and members of Dale, as well as our legislative body and others, as we think about how we want to create a health system. And their leadership has really helped us take the approach in that way and really look at everything from risk reduction and stigma reduction and what individuals can do all the way across the board to what has to happen in a medical facility or with a medical provider. And so I just really appreciate that they have that whole system approach and encourage all of us doing this work to do that as well. So